Stages of fracture healing pathology. Definition: a fracture is a break bent in the structural continuity of a bone. It may be more than a crack, a crampling, or a splintering of the cortex. More often, the break is complete. The resulting bone fragments may be displaced or undisplaced. If the overlying skin remains intact, it is a closed fracture. If the skin or one of the body cavities is breakage, it is often an open fracture, also known as a compound fracture, liable to contamination and infection. How fracture occurs? Fracture are caused by injury, repetitive stress, abnormal weakening of a bone, a pathological fracture. Fracture due to injury. Most fractures are caused by sudden and excessive force overloading, which may be direct or indirect. Direct injury. With the direct force, the bone breaks at the point of impact. The soft tissue are also damaged. A direct blow usually splits with the bone transversely or may bend it over a fulcrum so as to create a break, a butterfly fragment. Damage to your overlying skin is all common. If crushing occurs or in high energy injuries, the fracture pattern will be comminuted with extensive soft tissue damage. Indirect injury. With, a, with an indirect force, the bone breaks at a distance from where the force is applied. Soft tissue damage at the fracture site is not inevitable. Although most fractures are due to combination of force like twisting, bending, compression, or tension, the dominant mechanism is revealed by X-rays. X-rays. Twisting causes a spiral fracture. Compression causes a oblique fracture. Bending results in a fracture with a triangular butterfly fragment. Tension tends to break the bone transversely. In some cases, it may simply avulse a small fragment of bone at the point of ligament or tension insertion. Repetitive stress, fatigue or stress fracture. These fractures occur in normal bone which is subjected to repeated heavy loading, typically in athletes, dancers, or military personnel who have grueling exercise programs or when the intensity of exercise is significantly increased from baseline. The heavily loading creates minute deformations that initiate the normal process of remodeling combination of bone resorption and a new bone formation in accordance with Wolff's law. When exposure to stress and deformities, repeated and prolonged resorption occurs faster than replacement and leaves the area liable to fracture. Stress fracture are increasingly seen in patients with chronic inflammatory disease who are on treatment with steroids or methotrexate. Pathological fractures. Fractures may occur even with the normal stress with the bone as being weakened by a change in its structure. Example in osteoporosis, osteogenesis imperfecta or Paget's disease, or through a lytic lesions, example bone cyst or a metastasis. Types of fracture: complete fracture or incomplete fractures. Complete fractures. The bone is split into two or more fragments. The fracture pattern on X-ray can be helped to predict the behavior after successful reduction. Types of complete fracture are transverse fracture, oblique or spiral fracture, impacted fracture, comminuted fracture. Transverse fracture. In a transverse fracture, the fragments usually remain in a place after reduction. Oblique spiral fracture. In a oblique or spiral, they tend to shorten and redisplace even if the bone is split. Impacted fracture. In an impacted fracture, the fragments are jammed tightly together and the fracture line is indistinct. Commuted fracture. A commuted fracture is one with more than two fragments because there is poor interlocking of fracture surface. They are often unstable. Incomplete fracture. The bone is incompletely divided and the periosteum remains continuity. Green stick fracture, plastic fracture, compression fracture. Green stick fracture. In a green stick fracture, the bone is buckled or bent, like a snapping a green twig. This is seen in children whose bones are less brittle than those of adults. Plastic fracture. Children can also sustain injury where the bone is plastically deformed, misshapen, without there being any crack visible on X-ray. Compression fracture. Compression fractures occur when a cancellous bone is crumpled. This happens in adult and typically where this type of bone structure is present. Example in the vertebral bodies, calcaneum and tibial plateau. Classification of fractures. An alphanumeric classification developed by Muller and colleagues. Muller et al. 1990, Mersch et al. In 2007, Slango and Odigi in 2007, known as AOTA classification, fulfilling the objective of being comprehensive, now has been adapted and revised. Muller classification of long bone fracture, where the anatomic region and where the morphological characters. In anatomic region, bone 1, 2, 3, 4 segments like 1, 2, 3, 4. Where in morphological character type A, B, C, group 1, 2, 3. For example, 22A3 is forearm to shaft to simple A, group 3. Stages of fracturing. Fracturing is characterized by process of new bone formation with fusion of bone fragments, proliferative physiological process in which the body facilitates a repair of bone fracture. Primary and secondary. Primary without callus formation of fracturing, secondary with callus formation fracturing. Primary bone healing. Healing by direct union requires a correct anatomical reduction which is stable without any gap formation. Requires only remodeling of laminar bone, eversion canals, blood vessels without callus formation. Contact healing and gap healing. Contact healing. Criteria are gap between the bone end is less than 0.01 mm. Interfragmentary strain is less than 2%. Remodeling without callus. If the fracture site is absolutely stable, osteoblastic new bone formation occurs directly between the fragments where the exposed fracture surface are in direct contact and held from the outset with absolute stability. Internal bridging may occur without any intermediate stages like soft callus, hard callus formation. Gap healing. Fracture gap is 800 micron beta to 1 millimeter. Osteogenesis produces lamellar bone. Wider gaps are filled by open bone, which is then remodulated to lamellar bone. By 3 to 4 weeks, the fracture is solid enough to allow the penetration and bridging of the area by bone remodeling units. That is osteoclastic, followed by osteoblast. Secondary bone healing, healing with callus. Healing by callus through less direct has a distinct advantages. It ensures a mechanical strength while the bone ends in. And with increasing stress, the callus grows stronger and stronger, according to Wolff's law. The heavy loading creates a minute deformations that initiate the normal process of remodeling. A combination of bone resorption and a new bone formation in accordance with Wolff's law. Stages of secondary healing: hematoma formation, inflammation, soft callus formation, hard callus formation, remodeling. Detailed discussion will follow. Hematoma formation. At the time of injury, immediately after the fracture, the bleeding occurs from the bone and the soft tissue. Bleeding occurs due to rupture of blood vessels that cause hematoma, which fills the fracture gap and surrounding the area of bone injury. Inflammation. The clotted blood provides fibrin mesh sealing of the fracture site, and at the same time it creates a framework for the influx of inflammatory cells and ingrowth of fibroblasts and new capillaries, simultaneously degranulated platelets and migrating inflammatory cells release PDGF and TGF beta FG fibroblast growth factor and other factors. The platelet-derived growth factor, transformant growth factor beta, which is produced by WBC, when fibroblast growth factor, which activates the osteoprognator cells in periosteum, medullary activity, and the surrounding soft tissue. These osteoprognator cells stimulate the osteoclast and osteoblast activity. A picture which shows the active osteoblast synthesizing bone matrix. The surrounding spindle cells represent the osteoprognator cells. Picture B shows two osteoclasts resolving bone. Soft callus formation. Thus, by the end of the first week, the major changes are organization of hematoma, matrix production in adjacent tissues, and remodeling of fracture ends of the bone. This fusiform and a predominantly unclassified tissue called soft tissue callus or a procallus, which provides some anchorage between the ends of the fracture bones, but not structural rigidity for big weight bearing. Soft callus formation. This shows a new bone vessels, external callus and the internal callus. Hard callus formation. After approximately 2 weeks, the soft tissue callus is transformed into a bone callus. The activated osteoprognator cells deposit the subperiosteal trabeculae of open bone that are oriented perpendicular to the cortical axis and within the medullary cavity. This shows you the first picture, which shows you the open bone is more cellular and disorganized than lamellar bone. In some cases, the activated mesenchymal cells in the soft tissues and the above surrounding the fracture line also differentiate into chondrocytes that mark fibrocartilage and hyaline cartilage. The bony callus reaches its maximum growth at the end of the second or third week, helps to stabilize the fracture site. Remodeling. The newly formed cartilage along the fracture line undergoes encorneal ossification, forming a contagious network of bone with newly deposition bone trabeculae in the medulla and beneath the periosteum. In this fashion, the fracture ends are bridged, and as it is mineralized, the bone is mineralized mesenchymal tissue. The stiffness and strengthness of callus increases to the point that controlled weight bearing is tolerated. Remodeling, long process of years, resorption of remaining cartilage, resorption of aggression system, no scar formation, active growth plate with ongoing enchondral ossification, reverse zone, reserve zone, reserve zone, zone of proliferation, zone of hypertrophy, zone of mineralization, primary spongiosa. In the early stages of callus formation and excessive of fibrous tissue, cartilage woven bone is produced. As the callus matures and subjected to weight-bearing force, the portions that are not physically stressed are resolved. In this manner, the callus is reduced in size and the shape and outline of fractured bone are re-established as a lamellar bone. The healing process is completed with restoration of the medullary cavity. Pathology of fractured bone. The sequence of events in the healing of fracture can be easily impeded or even blocked. For example, displaced and comminuted fractures frequently result in some deformity. Inadequate immobilization permits movements of the callus and prevents its normal formation, resulting in delayed union and non-union. If the non-union persists, the malformed callus undergo cystic degeneration, and the luminal surface can actually become lined by synovial lining, now synovial-like cells, creating a false joint or a pseudoarthrosis. Pseudoarthrosis. Non-union may be painless. If pseudojoint is formed between the fracture ends, active movements are possible. No synovial capsule. Pseudoarthrosis types are atrophic, oligotrophic, hypertrophic pseudoarthrosis. A serious obstacle to healing is infection of the fracture site, which is especially common in open fractures. Malnutrition and skeletal dysplasia also hinder fracture. In children and young adults, near perfect union is known. In older adults, fracture often occur in the background of the bone disorder. Example, osteoporosis and osteomalacia. In such settings, surgical immobilization is often needed for adequate